Stroke can be caused by a number of causes, such as cardiogenic causes, rheumatological causes, hematological causes, and other causes. The cardiac causes of stroke include left atrial thrombus, atrial myxoma, paradoxical embolism, infective endocarditis, myocardial infarction, dilated cardiomyopathy. In the rheumatological causes, we are looking at systemic lupus erythematosus, which is SLE, and APLA syndrome, which is antiphospholipid antibody syndrome, rheumatoid arthritis, Sjogren's syndrome, and a few other syndromes as well are going to cause stroke. Sickle cell anemia, polycythemia, thrombocytopenia, idiopathic thrombocytopenic purpura, hemolytic uremic syndrome. These are protein C, protein S deficiency, paroxysmal nocturnal hemoglobinuria. All these things can also cause stroke. They all come under the hematological causes of stroke. Moving on to the most common cause of stroke in women in India, it's going to be oral contraceptive pills. The oral contraceptive pills is going to cause cortical vein thrombosis. That's how the person gets stroke. And then other causes of stroke can also be there. For example, cocaine, amphetamine, especially we are going to suspect cocaine, amphetamine in a person who is young and person who is a male. Again, atypical presentations are also not very rare. And apart from that, other causes can be infections like tuberculosis and mucormycosis and nephrotic syndrome. Pregnancy can also cause stroke. Moving on to the symptoms of stroke. So first we're going to talk about ABCD2. ABCD2 is nothing but the risk of stroke following a TIA, the transient ischemic attack. Before going into the details, let's first see the definition of stroke as such. So stroke is nothing but abrupt onset of a non-convulsive focal neurological deficit. The signs and symptoms last for more than 24 hours. That's the definition of stroke. What is TIA then? TIA stands for transient ischemic attack. The focal neurological deficit resolves completely within 24 hours in case of TIA. So following a TIA, in order to find out the risk of the person developing a stroke, is going to be given by the score called ABCD2 score, where A stands for age, B stands for BP, C stands for clinical presentation, D for duration, and D for diabetes. So the age is, okay, we're going to score the person based on all these criteria. If the age of the person is more than or equal to 60 years, the score is 1. The blood pressure, if it is more than 140/90, the score is 1. Based on the clinical symptoms, we are going to grade it as scores 1 and 2 are given. The score 2 is given in case there is a unilateral weakness. A score of 1 is given if there is a speech disturbance without any weakness. And the first D is duration. Duration is nothing but, so again we're going to give two different scores, 1 and 2. If the duration is more, that is more than 1 hour, we're going to give a score of 2. But if the duration of the TIA is somewhere between 10 minutes and 59 minutes, you're going to give a score of 1. I think it's pretty obsolete to, just label a person as stroke. Say for instance, the person is the duration of stroke or the TIA, the focal neurological deficit. If it is for a period of 59 minutes, or say 58 minutes along with the 59 seconds, so that does not make it any less than the stroke of 60 minutes duration, right? I mean, this cutoffs does not make so much clinical sense, but then I think in day-to-day practice, to some extent it helps us to classify based on the severity of it. So it's fine. Diabetes, so the person has diabetic and person is on insulin or any oral medications for diabetes, we're going to give them a score of 1. So that's how you're supposed to score based on ABCD2 score, which is age, blood pressure, clinical presentation, duration of TIA, and diabetes. Moving on to other types of involvement in case of stroke, which are distinct clinical syndromes associated with lacunar infarcts. Lacuna infarcts are nothing but lacuna is nothing but a very small blood vessel. So lacuna strokes are those strokes which involve the lacunar blood vessels, like small vessel strokes. So it can, if the internal capsule is involved, we are looking at a motor problem. So it's a pure motor hemiparesis. In addition to internal capsule, pons corona radiata can also be involved. Pure sensory stroke is going to be involving the thalamus. Sensory motor stroke is otherwise called the mixed stroke. It's going to involve both the internal capsule and the thalamus. Moving on to the ataxic hemiparesis. Ataxia occurs again, the same thing as the motor one, internal capsule, pons, the corona radiata. Dysarthria clumsiness syndrome, internal capsule or the pons is getting involved. So based on the area, the artery which is affected, let's try and localize what happens to the body. So if it's an anterior carotid artery infarct, anterior cerebral artery infarct, we are looking at a problem with the leg. Okay, so anterior cerebral artery infarct, the problem is in the leg because the paracentral gyrus, which are going to be supplied by the anterior cerebral artery, is going to be screwed up, so the leg is going to get affected. So we are looking at a bilateral lower limb paralysis, sensory loss in the same area, so in the legs. Apart from that, we are also looking at urinary incontinence, but the main thing is the leg is involved. Middle cerebral artery infarction is going to involve the face, arm, and the leg, and the contralateral aspect. So the trick over here is the anterior cerebral artery. The anterior cerebral artery, right, that's also contralateral. But sometimes what happens is the paracentral gyrus is going to be supplied by the anterior cerebral arteries branch from either the right side or the left side. So if it's that way, then both the legs are going to get affected. Otherwise, it's only the contralateral leg. Middle cerebral artery is always involves the contralateral face, arm, and also the leg. There is paralysis of all these. Apart from that, the middle cerebral artery, is also going to cause, because it's going to supply the parietal lobes, it's going to cause the hemi-neglect, which is a very fancy name. Means the person is going to neglect the opposite half of the body as such. Right, so the person has a problem with, like, the infarctus on the right side. The person is going to neglect the right side of the body, meaning, right, okay. And then moving on to the posterior cerebral artery, homonymous hemianopia with macular sparing is seen in case of posterior cerebral artery problem, because it's going to supply the occipital part. So occipital cortex has to do with the vision, right? Moving on to the basilar artery. The basilar artery involvement is going to cause a syndrome which is called the locked-in syndrome. It's a very nice syndrome, by the way, but very nice clinically, but not for the patient, clearly. Locked-in syndrome is nothing but the person will be able to see things, the person will be able to hear things, person will be able to see, think, do everything except react. So the person will not be able to react. The only thing he will be able to do is blink. That is the only thing he'll be able to do. He won't be able to move even his toenail. Okay, usually we don't move the toenails. It's actually the toe wriggling. Anyways, and then moving on to the another two important or like interesting facts about it. It's CADASIL and subclavian steal syndrome. CADASIL stands for cerebral autosomal dominant arteriopathy. A is arteriopathy because the blood vessel, and SIL is subcortical infarcts and leukoencephalopathy. So once more, say it with me: cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So that's another problem. Okay, there's just progressive dementia along with extensive white matter changes. So there's memory loss, that is CADASIL. Subclavian steal syndrome is because of occlusion of the subclavian artery proximal to the origin of the vertebral artery. So what happens here is that when the person is standing up and doing some work. Okay, so when the work with his hand, when the demand of the hand is very high, the blood flow is going to be from the vertebral artery to the hand. So like instead of the, okay, so there's preferential flow. Okay, what happens is that whenever the person is going to work with his hand of the affected side, the person is going to faint. It's basically because the work on the hand is going to necessitate more increased demand for blood. And as a result of which, the person is going to use the hand and the blood is going to come to the hand, but at the cost of the blood going to the brain. So the blood does not reach the brain because there's a preferential flow to the axillary artery through the subclavian artery. Because of the obvious reason, there is some sort of constriction in there, stenosis or occlusion. Moving on to the investigations, we are going to look at 8 investigations here: CT, MRI, FLAIR, MRI with fat saturation, cerebral angiography, ultrasound, PET scan, SPECT. Let's see one by one. CT scan is very good. Actually, what we are doing is non-contrast CT. CT is a very fast modality to find out stroke. I mean, there are 2 types of stroke, broadly speaking: ischemic stroke and hemorrhagic stroke. Ischemic stroke, fancily 85% most common. Hemorrhagic stroke is only 15%. So the question is, why are we using a CT scan? I mean, CT scan will show if there's a hemorrhage, right? I mean, it makes sense, right? The question makes sense, but I've got the answer for it. So the CT scan will show hemorrhage. So if the hemorrhage is present, it is a hemorrhagic stroke and we can treat it accordingly. If the hemorrhage is absent, there's just one more guy. That's ischemic stroke, right? So CT invariably rules out hemorrhagic stroke, thereby re-emphasizing on the fact that ischemic stroke is very common. We're going to treat if the CT is completely normal. We're going to treat the patient as ischemic stroke. Got it? That's right. CT is going to show hemorrhagic stroke better. Okay, so what happens in an ischemic stroke is that the CT will not be able to demarcate the areas where there is ischemia, especially if it's going to be a small cortical infarct or a posterior cranial fossa infarct. There is no way that CT can detect it. Infarcts can be detected after 1 or 2 days, but I mean, after that much amount of time, we are not hoping to regain the whole motor system, the sensory system of the patient. Obviously, earliest intervention and within the golden hour of 4.5 hours is very crucial. So CT is, however, better in detecting hemorrhage when compared to an MRI. But however, up to 12 hours, the CT may be completely normal in an infarction. And some low attenuation is seen somewhere between 24 and 36 hours. A mass effect is seen between 2nd and 3rd day. The mass effect is going to subside by 7 days. After 7 days, because of new vessel formation and hemorrhage, all the blood is going to be seen better on a CT scan. There are areas of increased attenuation, okay, after 7 days. And after 14 days, there will be areas of enhancement, especially because of the neovascularization. All right. Moving on to MRI. MRI is going to detect ischemic stroke very well in all the locations of the brain, even in the posterior cranial fossa and the deep white matter lesions, everything. And then FLAIR. FLAIR stands for fluid attenuated inversion recovery. So that's also one type of MRI to detect ischemic stroke. MRI with fat saturation is going to mainly detect and visualize the intracranial and extracranial arterial dissection. So there is an arterial dissection, meaning the blood is going to flow in between the walls of the arteries by chance, through an injury to the endothelium. Then we are looking at MRI with fat saturation. Moving on to cerebral angiography. Cerebral angiography is going to show us atherosclerotic changes or stenosis within the cerebral blood vessels like anterocerebral artery, middle cerebral artery, posterocerebral artery. Now, apart from that, you can also find out whether, okay, this picture over here looks like a hedge. It's actually AV malformation. So arteriovenous communications will be seen too. aneurysm, stenosis, and atherosclerosis. And other vessel problems could also be seen with cerebral angiography. Moving on to the ultrasound. Ultrasound is to assess the flow velocity. PET scan, it stands for positron emission tomography. It is to quantify the cerebral blood flow. Moving on to the SPECT. SPECT stands for single photon emission tomography. It's also one of the imaging modalities, and that's it. So investigation, you're gonna jot down these 8 points, and then we're gonna expand a little bit on the CT scan, a little bit on the MRI with fat saturation, a little bit on cerebral angiography, and we're gonna be acing the test. Moving on to the treatment, first thing first, BP has to be corrected using esmolol and mannitol and heparin. Esmolol is used if the BP is crazy high, like 185, 110, then esmolol is used. For your information, esmolol is a beta 1 blocker. And in case a person has a deep vein thrombosis, we might want to give heparin. And in case a person is going to has cerebral edema, we are going to give IV mannitol. The cerebral edema typically happens 48 to 72 hours after stroke, so just be cautious. And second treatment is antiplatelet drug. The person is already on aspirin. I mean, the antiplatelet drugs which can be given are aspirin, clopidogrel, prasugrel, abciximab. Okay, abciximab is nothing but a GP2B3A inhibitor. Okay. Right. So the person is on a long-term aspirin therapy. We're not supposed to add clopidogrel to aspirin. You can stop aspirin completely and give clopidogrel. Okay. Otherwise, you can only give aspirin along with dipyridamole. Again, clopidogrel can be given with dipyridamole. So you're not supposed to combine aspirin and clopidogrel. Those two guys will fight with each other. So it just screws up everything. All right. Anticoagulation, the agent of choice is heparin. And the thrombolysis can be given. Thrombolysis is done by RTPA. RTPA stands for recombinant tissue plasminogen activator. So there are certain indications why when we can do RTPA, it should be ischemic stroke. That's when we have to give RTPA. If it's a hemorrhagic stroke, I mean if the CT is going to show a hemorrhage, we're not supposed to give it. So CT showing no hemorrhage and no cerebral edema, we can give RTPA. Person's age should be more than or equal to 18 years, and the symptoms onset should be less than 3 hours, and the clinical diagnosis of stroke has to be made. As far as today, we can give RTPA. Maybe we can give statins along with it, mainly to for cholesterol, for atherosclerosis and stuff. And finally, neuroprotective agent, hypothermia can be given. What hypothermia does is that it's going to prolong the tolerance of the brain to ischemia long enough to allow other interventions taken by doctors. So hypothermia technically buys more time for us to prevent the person's death, right? Okay, so basically the aim of the treatment is to prevent the brain damage or to reverse the brain damage. I think it's done with that. Thank you.